Okay.
All right. So Dr. Campbell challenged me to break down some of the safety bundles and what does that actually mean and what can that mean for your practice. So that's kind of our goal for this first little part of our presentation today. So what is a safety bundle? So the IHI, Institute for Healthcare Improvement, gave a definition of a safety bundle as a structured way of improving processes, care processes, and patient outcomes. So it's not anything brand new. You'll see that these are all based on evidence-based practice that's already out there, but it helps to align what should be happening when we talk about a specific issue. So the two that we're going to talk about today are OB hemorrhage and then our hypertension in pregnancy. So the idea is that they are supposed to be universal and implemented, that's easy to be implemented in every facility, and it's a multidisciplinary approach. So this website, Safe Healthcare for Every Woman, is the best resource for you to go to, and that's where all of this information has come from. Next slide. So AIM and the Safe Healthcare for Every Woman is an organization that South Carolina is lucky enough to be part of, and they do give some suggestions on implementing a bundle. I would recommend, because we do have hospitals from multiple areas of the state, reach out to your regional perinatal center and your perinatal systems offices if this is something that you are not fully aware of or you need some help in working with this. Next slide. So I just did include that AIM as an arm of ACOG has worked really hard to get states on board, and we're glad that South Carolina is finally one of those states. And there are lots of different programs that are happening throughout the nation for participation within AIM. Next slide. So the AIM bundles are all broken down into what we consider the 4 R's. So readiness, recognition and prevention, response, and then our reporting and systems learning. So readiness is the idea that every facility, doesn't matter what level delivery hospital you are, you have objects in place that allow for everyone to be prepared for an event to happen. Because if you're delivering babies, there is an opportunity for things to happen. Next is recognition and prevention. So that R really focuses on when the patient is in your care, what are the steps that help us to be able to realize that, oh, there's a high blood pressure, or, oh, she's starting to bleed. So what are all the things and components that can happen in that day-to-day care? The next R is response. That's what we actually do. And then the reporting and systems learning, that is looking at it afterwards. That's part of the debrief process. That's part of some of the data collection and looking and seeing, what are we doing? Are we making a difference in our care once we implement these bundles? So this is what the bundle looks like, and I know it's teeny tiny, so you're not going to be able to see this, but you can pull this off as a printable PDF, but the next slide you're going to be able to see a little bit better, so we'll go on to that. So, and my sizing on my boxes got off a little bit, so I apologize for the dangling E's that are there, but so this is, readiness. So the idea behind all of these bundles is that every patient at every facility every time gets the exact same care. No matter where you are and who you are, there is a system set up. So the idea behind these bundles is that the term that the national office uses is steal shamelessly and share avidly. So we want to make sure that we're taking information. People across the nation have already developed protocols and procedures. You take that, you tweak it to make it work for you, and then you have that. But the idea is that we are using it for every unit is prepared. Because if you're delivering babies, when we're talking about the hemorrhage bundle, we have to be prepared that someone might bleed. So the first piece of this, the checkbox that we're looking at is, do you have a hemorrhage card? And so we know that with the South Carolina BOI and the SimCoach training, we were able to get all of our delivery hospitals, if they didn't already have a hemorrhage card in place, we were able to get a hemorrhage kit for them. So every hospital, yay, we have a check in for one of these factors. So everyone has a hemorrhage kit. Now, it's up to the individual hospital to make sure all those kits and carts and whatever it is you have are fully stocked with your supplies. The next is having immediate access to your hemorrhage medication. So that's helping hospitals or units, delivery units and postpartum units have access to your Hemabate, your Methergin, your oxytocin immediately available. Then we have our response team. So we have to have in our protocol in that unit who's going to be called, who are all of our support people. And if I am, for example, in a level 1 facility, who else do I have as a resource that we can call? Can I call my RPC to get prepped for in case we need to transfer that patient to a higher level of care? One big component, you'll see the blue, is establishing a massive transfusion protocol. I recognize fully that not every facility is going to have access to large amounts of blood. And that's really what a mass transfusion is mass amounts of blood. And they keep sending the blood and the FFP and the cryo, everything that we talked about last week or last time, that you may not have access to, you may have a limited number just because your facility has a limited amount. But it's important to know and to make sure the blood bank is aware that if you're delivering babies, when you ask for the blood, you get it and there's not any delay in that. And then what is the process when you've used the amount of blood that's available to you? So we want all of the providers to know how much blood is available to them and how we can get that. And then the last piece of the readiness is doing unit-based drills. So it's very important to make sure that we're utilizing, it can be high fidelity, low fidelity. And again, we're very lucky in South Carolina that we have a process through BOI that we can send out the sim coach once a year to practice some of these types of drills. And hemorrhage is one of those things that we practice. Next slide. So recognition, this comes into, and the way that I like to think about this is years ago in medicine and health in general, it was really bad to have a checklist. Like we were supposed to remember everything. And we've adopted the thought that we can have checklists and checklists are a good thing and we should check off things in that checklist. So we want to have an assessment of hemorrhage risk for every patient. Every patient that comes into our facility is assessing that risk. And the slides from the last time we talked about risk assessment specifically. So for every patient, multiple times throughout their pregnancy and delivery that we want to assess that risk of hemorrhage. Then we want to have that measurement of cumulative blood loss, which we talked about, that quantified blood loss. And remember that should be cumulative. What she lost in delivery, what she lost in the early postpartum, what she lost in the later postpartum, all of that adds up. And then having an active protocol for third stage of labor as well as in that postpartum period. So if she starts hemorrhaging, do we have a protocol for that? So every patient gets that. Next slide. And then our response. So again, this is having that checklist, that protocol, whatever that management plan is for your hospital that is specified for your hospital. So I'm not going to print one off from Richland and send that. I'm going to pick on Dr. Pletzka because she's here, that's going to work exactly for Clarendon because it's not. They're going to have it individualized for their facility. And that's what we want. So we want to say, this is what the standard is. How can you make that work for your hospital? And the next piece of the response is, what do we do for our patients and their families and for staff when there are bad things that happen? We know we debrief, or we should be debriefing when we have these events like a hemorrhage, but is there support for the family? That becomes a PTSD kind of thing that might happen for that mom. What kind of support do we have for her and her family? Especially if, for example, she has to be transferred to a higher level of care. Where does the baby go? Is the baby going there? How's the family going to get there? All of that kind of goes into that process. And so the last one, and this is the one that I'm like, oh, we'll let the number cruncher people take care of this, but it is important for us to be aware of what's going on. And we want to establish a culture change. So again, we went from every patient to every unit. And again, we want the culture change that everyone, multidisciplinary, and it doesn't matter who you are. You could be the person coming in to help clean up the room and say, hey, did you guys see all this blood that's under the bed? Did that get counted? That's an important important person to have on your team as well. So we want to have a situation where we're huddling, maybe pre-event, we're huddling mid-event, we're making sure we're communicating. So how are we addressing what's happening with those individual hemorrhages in this example? And we also want to identify our successes. We can't always just point out all the things that went wrong. We've got to remember to point out the things that go well. We do want to have a multidisciplinary review of hemorrhages for systems issues. Is there something happening within the system? For example, if the lab is creating, if there's a problem with the lab and getting results back from the lab, or I can't get the blood up from the blood bank, or I'm having trouble getting meds up from the pharmacy, we need to know what those process errors are, and that's where this comes into play. And then, of course, we've got to look at our numbers. Next slide. So that's the 4 R's for our hemorrhage. And Dr. Campbell also wanted me to break down the 4 R's for hypertension. And you're going to see that it's got the same readiness, recognition and prevention, response, and reporting. But this time we're changing gears to that hypertensive disorder. Next slide. There we go. So when we look at readiness for our hypertensive disorders is having early warning signs. And this is something that we can't talk about enough. I feel like having patients aware of warning signs, our staff, nursing, physicians, everyone involved, having warning signs, diagnostic criteria. Are we following algorithms? Do we have order sets that are based on the evidence-based standards in order to be able to process through what's happening? If a mom has a high blood pressure, what are we doing? Does the staff have that process in place? We need to do drills again, and this time the drills are talking about what do we do in order to maybe prevent those seizures from happening, or if I do have a mom that has a seizure, do we have a process in place for that? So we want to practice with drills in our post-drill debriefs. Timely triage. So this goes back into the early warning signs. So we want to have a system in place in our facilities that we are timely triaging and evaluating our patients. So if 3 patients walk in the door and I have one that's come in for rule out labor, and I have another one that's coming in with severe headaches and epigastric pain, and then she should probably, the second patient that showed up should be seen first, perhaps, instead of the rule out labor patient. So it's making sure that we are evaluating our patients as they're coming in, depending on what their complaints are and what their risks are. AWHONN has a great resource for this, kind of that prioritization of the care for our patients. And I'm more than happy to share that during the discussion. So I'll pull that up and be ready to share that. Next is having available medications. So obviously we want to have our magnesium sulfate on our unit and readily available. We want to have our labetalol. We want to have our hydralazine, whatever it is that your hospital uses, you want to have that stocked and ready to go. We don't want any delay in getting those medications. We also need to have a system in place for escalation. And this talks about our regionalized system of care in South Carolina, which is great. We are so lucky to have a system in place where our hospitals have a very clear understanding of how you get to your regional perinatal center. For recognition, again, this is a standard, number 1, standard protocol for measurement and assessment of blood pressure. So I know that when I'm teaching nurses, they'll sometimes talk about, well, what do you do when you've got a patient whose arm is so large and the blood pressure cuff doesn't fit on that? Well, have we talked about that? Is there a system in place for your hospital? Do we have the extra large cuffs? You know, what is that process? That needs to be addressed on the front end so that we know what to do for every patient. We do also want to have a standard response for those early warning signs. So we have our risk assessments, and then we have what do we do about them. So that's that every patient gets this. And we want to have facility-wide standards and education for our perinatal patients. What are the signs and symptoms of hypertension? Do our staff know the signs and symptoms? If I have a tech that went to go grab a blood pressure, does she know what that severe range blood pressure is? Does she know what that elevated blood pressure is? He or she, I should say. All right, next slide. So response, and you can see for response that it's having facility-wide standard protocols and checklists and escalation policies, again, very specific to what do we have, what are we supposed to do when we have severe range hypertension, so that 160 over 110. What do we do if a patient has a seizure? What is that immediate prophylaxis for mag sulfate? And what do we do if there's a mag overdose, which we know is a high possibility with patients that have eclampsia because they're not perfusing to their kidneys? What do we do when a postpartum patient presents to our hospital? Where do your postpartum patients go? We know that a lot of our postpartum patients are going to present to your ED. So does the ED staff know how to recognize an elevated blood pressure in a postpartum woman, which is going to be significantly lower than what they're used to seeing for their high blood pressures? So it's remembering to ask every female of childbearing years, have you recently had a baby or could you be pregnant? In order to make sure that we're keeping that assessment involved in the perinatal period and remembering that, because we're going to treat those patients very differently if she's postpartum or pregnant with those blood pressures that normally our ED would just kind of laugh at and say, well, that's not really an elevated blood pressure, but it really is for us when we're talking about our pregnant women. And so then having a protocol kind of lined up here. So what do you do? I will say that at Richland, as an example, we have changed that our new postpartum moms come straight back up and we triage in our OB triage kind of ED unit in labor and delivery, so that those postpartum women are not sitting down in the ED. So it's kind of figuring out what you can do in your facility to help improve that care. Next slide. And then our reporting systems again. So it's a culture of safety again for our huddles, making sure that we are all working together to identify opportunities for improvement and our successes, reviewing as a multidisciplinary group all of those cases. It's also important to know if I've got a mom that came in and she's severe hypertension and we've got preeclampsia and eclampsia and we deliver that baby, well, what happened to the baby? What's the rest of the story? And so that's an important part of all of us kind of working together in that multidisciplinary arena. And then we've got the numbers that we have to look at. So that's the last slide that I have, I think. And there's Dr. Campbell's slides will come up. So if anyone has any specific questions, we'll do questions at the end. Is that right, Rachel?
Yes. And so I just want to say thank you so much. And we tentatively have on file for July 7th, diagnosis and management of, I'm not sure how to pronounce that, Dr. Campbell.
Abruptio placenta and placenta previa.
Yes, and I knew that. So I knew there was an R missing there. Abruptio placenta and previa.
That's right.
Missing the R there. Okay, and which Dr. Campbell will be presenting on. So I'm going to go ahead and stop